Thank you so much for the opportunity to present our project, Rhabdomyolysis, a need for evidence-based interventions to decrease health disparity and improve standards of care. I'm Dr. Natasha Shur, a medical geneticist at Children's National in the DC area. Some of you may have heard of rhabdomyolysis, a disease of muscle breakdown associated with spin cycle classes or marathon runners. But in fact, many children, adolescents, and adults come into the hospital after a virus. Some have genetic disorders. Others, it's out of the blue, and these kids are in severe pain in their legs, chest, abdomen. They experience muscle cramping due to muscle injury. And this disease can cause severe kidney damage and even be life-threatening. In recent years, we noticed something very unusual about our rhabdomyolysis cases. This disease has been disproportionately affecting communities of color. For example, at Children's National, over 50% of patients who come in with rhabdomyolysis are reported to have Black race. Only 17% are Caucasian. And nationally and internationally, there is a twice as much increase as expected of Black race and other patients from communities of color. There are over 26,000 hospitalizations with rhabdomyolysis per year, and this disease is increased with sickle cell trait and escalating with the COVID-19 pandemic. Unfortunately, treatments are very limited, just IV fluids and supportive care. More has been done in race horses, where they try a medication called dantrolene before the race to decrease the chance of rhabdomyolysis. And the military is studying agents that decrease the risk of kidney function. But meanwhile, patients who are diagnosed, and the 1 in 10 with rhabdomyolysis that go on to have many recurrent admissions, face severe exercise restrictions. I've seen kids who've had to quit football or crew because of this, whose lifestyle, whose future is changed. I think that we can do better. And many years ago, I had a very sick 4-year-old with a rare metabolic condition that caused rhabdomyolysis, and his CK, a measure of muscle breakdown, was rising. He was in pain. I was extremely worried, and I called people around the country until one expert said, try some steroids. And when I did, and the steroids worked remarkably well, this inspired me to read more about the pathophysiology and try this approach again. And over time, we published a protocol and our experience with a few patients where steroids have been successful. And I want to share one patient's mother describing her particular case.
Dr. Shur and the team kind of mentioned starting some steroids to see if we could get the numbers down, because his numbers were like triple the number in his CK level that it was supposed to be. So it was a really scary situation, and my mom's in a lot of pain. And so Dr. Shur and the genetics team came in and started the steroids. We noticed once the steroids started and got really good into this system that pain went away, the numbers went down. It was just like, oh my goodness moment for us.
And in thinking about her case and how not every child receives this treatment when coming in, we decided it was time to do something different and perhaps try a trial where we chose steroids. In this particular case, we chose a steroid called dexamethasone because it's familiar, it's been used in pediatric asthma protocols, it's cheap and accessible. However, uptake of trying this novel approach has been limited. And in thinking about why, I wanted to describe the experience of a team member on a recent case. Why are physicians hesitant to try this?
I remember walking into pre-round the following morning after seeing my patient, and I heard the attending sharing with the senior resident, well, genetics team actually suggested dexamethasone. And I heard dexamethasone, what? And the attending just goes, yeah, I don't know, but we consulted them, so So we shrugged our shoulders and went ahead and did that for that day's plan. And the next day was the first day this patient's CK went down after continuously rising over 100,000 over a week, even with adequate IV fluids. And it was the talk of the next morning's rounds with relief and excitement and curiosity. So it's my impression that rhabdo has not been well talked about, especially based on the discussions my team had about the disease, also attributed by the limited exposure these physicians have had to it, let alone during my preclinical years of medical school. So the success in symptom relief was really incredible from dexamethasone.
In order to overcome that natural hesitancy to change decade-old protocols, we really need more data. And because of this recent case, so many physicians were garnered to help us to say we want to try something new at Children's National, one of the first pediatric trials for rhabdomyolysis, this underserved condition. So we have my colleague, Dr. Berger, who's a great researcher and statistician. We have emergency room physicians, we have hospitals, and a research team on board. We've already prepared a protocol. It just needs to be tweaked. We're looking at 10 years of natural history. We would begin active recruitment within the first 6 months. Community partnerships will be key, and we plan to analyze the data of dexamethasone along with standard care versus standard care alone within 3 years and publish our findings. Most of our budget would go to a research assistant who was on site and available to help both the hospitalist and the emergency room setting. And of course, there are other costs with any clinical trial that are fairly standard. But in thinking about our opportunity, we feel that this cheap, accessible, new repurposing trial could help us overcome the hesitancy of trying something new.